Hello, my name is Cherie Young. Today is September 3rd, 2025, and I'm interviewing Dr. Leo Happel on behalf of the Asset Historical Advisory Committee. Thank you for being with us today, Dr. Happel.
My pleasure.
Great. So, Dr. Happel, you are currently retired, correct?
Retired in quotes. As I was explaining a little bit earlier, when you are in academic medicine and you teach students, your students always feel like they have the prerogative of calling you when it's necessary, when they need something explained. And so I have a lot of surgeons that I had no contact with previously who call me and ask me questions and try to get me to explain what they are seeing in the operating room. This is becoming much more common now since my former head of neurosurgery, Dr. David Klein, passed away about 6 months ago. And so all the calls that used to go to him now come to me. And sometimes it gets really tough.
Yep. So there's no such thing as retirement, right?
Exactly.
Where did
Except
you,
that you don't get paid anymore.
right? Where did you receive your credentials for intraoperative monitoring?
I received my credentials when I was hired by LSU Medical School. I was hired by Dr. Richard Pattison, who was then the head of neurology, and he appointed me an assistant professor of neurology, even though I am a PhD, not an MD. And so, as a member of the faculty of the neurology department, that automatically gave me credentials at Charity Hospital New Orleans. Charity Hospital New Orleans was a teaching hospital. And so the teaching faculty came from both Tulane and LSU medical schools, the clinical departments. If you had a clinical appointment, you automatically had the privilege of seeing patients at Charity Hospital and performing testing on them. And that was that was how my credentials got started. I had to go through the process of acquiring other credentials. I had to show proof of malpractice insurance because you can't do anything clinical at Charity Hospital unless you had malpractice insurance. I had to go through training in basic life support because as a clinical faculty member, BLS credentialing was required. So I had to show proof of training in CPR. I had to be tuberculosis vaccinated. And with those credentials added to my academic credentials, I was approved for seeing patients at Charity Hospital.
Very good. And what drew you to evoke potentials in intraoperative monitoring? How did you get
Uh,
into that specific notch in diagnostic testing?
I guess I have always been an electronics geek. And as an electronics geek, when I was in graduate school, I familiarized myself with a lot of electronic equipment and basically did research in evoked potentials using the instrumentation that I had familiarized myself with.
Very good. So this wasn't very popular when you started your career. You're one of the
It,
original pioneers, correct?
it was fundamentally non existent. And the reason it didn't exist is there was no instrumentation that was in one box. You couldn't go to the company Nicolay because that didn't exist. You couldn't go to any of the other vendors of evoked potential machines to buy a machine because they didn't exist. So, what was necessary was to assemble a cart with all of the appropriate equipment. I had some grass amplifiers, and the grass amplifiers were particularly good for two reasons. Number one, these amplifiers had a very rapid recovery time. And so whenever the instrumentation was smacked by a large artifact, like the electrosurgical unit in the surgeon's hand, these amplifiers would recover very quickly. And another feature that these amplifiers had was they were optically isolated. So there was no grounding associated with the amplifier systems. And this was extremely important, especially at Charity Hospital New Orleans, because Charity Hospital New Orleans was a very old building. And all of the electrical wiring in this building was not electrically isolated like it is in all of the operating rooms today.
Wow.
So the optically isolated amplifiers helped a lot. In addition, I had some grass stimulators, and the grass stimulators were also optically isolated. And that precluded the necessity for grounding. Grounding was a real problem in the early days of neuromonitoring because one of the terrible things that would occur was the creation of a ground loop. And in order to try to avoid ground loops, I proposed something called Happel's Law. And I don't know if you remember Happel's Law. Happel's Law was never, ever attach more than one ground to a patient. It is never proper technique. Anytime a patient has more than one ground on their body, it is possible for their body to become involved in an electrical current path that is part of a ground loop. And electrical burns from the operating room were relatively common in the early 1970s.
Wow. So we've overcome a lot of challenges with our equipment these days, wouldn't you say?
Absolutely. The equipment manufacturers have really done a great deal for technologists who actually do the actual work. The inclusion of optical isolation in both amplifier systems and stimulator systems really precludes the possibility of ground loops. And so that is a huge help for us and takes away a lot of the risk associated with working in the operating room. Operating rooms are intrinsically high risk environments. They are very high electrical noise environments, and they present us with lots and lots of problems. One of the problems I had with working at Charity Hospital was the operating rooms there were extraordinarily small. These rooms were no more than 10 feet by 10 feet. And anytime you start packing in a lot of equipment, the room just disappears very quickly. I,
Right.
I remember walking into another hospital and walking into an operating room suite and looking at the operating room and looking and marveling at how big this operating room was. And the operating room there got to be very small by the time you put an EEG machine, stimulators, an X-ray C-arm, and all of the trays of instruments that the surgeons needed. By the time you put all that in the room got suddenly very, very small.
Oh my goodness. You've obviously created an environment to test and record evoke potentials in the operating room. Who would you say was the first manufacturer of this equipment?
The first manufacturer of the computer that I used was a company called Fabritech. And Fabritech made a computer of average transients. And that's what we needed to have to do the computer averaging that we do in monitoring. Fabritech was a company that was later purchased by Nicolay, and so it later bore the Nicolay name, but it was nevertheless the same company.
Okay. I remember back in the day at Tektronix, was that a computer you had built?
Uh, Tektronix was a display. Tektronix is a manufacturer of oscilloscopes. And so when I did surgical monitoring, not just to do for spine surgery or brain surgery, but for peripheral nerve surgery as well, the Tektronix became the principal source of amplification and display. Tektronix is a paragon name. Tektronix is a top-of-the-line oscilloscope and top-of-the-line manufacturer. And this was absolutely necessary to deal with all of the electronic problems that we would encounter in the operating room. I have to go back a few steps. I started working at Charity Hospital, not in the operating room, but in a program of research that the neurology department was conducting. The Department of Neurology was trying to study the development of the human brain. And the way they did that was recording evoked potentials of neonates and then following those neonates over a period of about 8 years and watching the development of evoked potentials as the brain developed.
Wow. Very interesting. Um, who would you say are some of your early mentors and earliest influences in your career?
This is kind of interesting. I'm glad you said early influencers because there were no real mentors. There was nobody who had real expertise in operative monitoring. Some of the people who were the early groundbreakers, there was a fellow by the name of Augie Moeller. Augie Moeller was particularly good in the area of brainstem auditory evoked potentials. And this is something that he performed during the removal of acoustic neuromas. And he was able to tell the surgeons what was happening to the point where he dramatically improved the outcomes of brainstem auditory evoked potential testing during acoustic neuroma removal. I would like to mention as a learning issue here, to this day, many people feel that if someone has an acoustic neuroma in, let's say, their left ear, there is no reason to do brainstem auditory evoked potential testing on their left ear. And they just leave all that off and they only do the right ear to measure what's happening in the right brainstem. And that's not really good technique. And the reason for that is when a person is deaf from an acoustic neuroma, most of the time they still maintain a wave 1 of the brainstem auditory evoked potential. Wave 1 of the brainstem auditory evoked potential originates in the distal eighth nerve. If that eighth nerve action potential is still present, it indicates that the arterial blood supply to the eighth nerve and to the cochlea is still intact. The blood supply to the cochlear artery comes through a blood vessel that we call AICA, A-I-C-A, anterior inferior cerebellar artery. And this artery supplies several things in the brainstem that are very much important. So it's still a good idea, even though a patient is deaf in one ear due to an acoustic neuroma, it's still a good idea to do the brainstem auditory evoked potential testing on that ear because it will still tell you something about the blood supply to the brainstem.
Right. So really, when you started, there was no training program. You did the training with physicians on
Yes.
peripheral nerve and moved over into evoke potentials and intraoperative monitoring. Where do you see us going in the future?
Wow. That is a really tough question to answer. Uh,
Certainly,
one of
we've
the
come a long way from where you started.
one of the problems with neuromonitoring is that it gets to be expensive. The equipment is expensive. The personnel required to do it gets to be expensive. One would think that it would be very easy for a single individual to bring the equipment in the operating room and record evoked potentials from a patient who is under anesthesia. It doesn't work out to be quite that easy. And the reason for that is the surgeons use some equipment that introduces vast amounts of artifact in the records. And if there is one thing that a computer system does not like, it's artifact. Transients that are presented to the equipment doing evoked potentials creates a noise problem that is so bad that it destroys the computer's ability to demonstrate the evoked potential. So we usually have to have two people in the operating room, one person watching what the surgeon is doing. And I remember that the early techs that worked with me would stand by me and stand up tall enough that they could see over the drapes and see what the surgeon was doing. And when the surgeon got ready to use the bovie, the electrosurgical machine, I'd get a tap on the head and I could quickly turn the inputs off so that this did not get into the computer and mess up the cumulative average of what was going on. So all of this adds to the expense. And if there's one thing that the medical insurance companies do not like now, it's expenses. And so they try to cut back on costs. And unfortunately, one of the things that's happening right now is there are many insurers who designate that they will not cover operative monitoring, even though operative monitoring has clearly demonstrated that it improves the outcome of particular surgeries. This happened first with the brainstem auditory evoked potentials and acoustic neuromas. When neuromonitoring was used in the case of removal of an acoustic neuroma, the outcome statistics was so much better than if monitoring was not used that some societies, like the American Academy of Neurology, came out with a position statement that said if you removed an acoustic neuroma without using auditory monitoring, you were practicing substandard medicine. And got to be a very profound issue for a long time. And to this day, most ENTs will use monitoring in the case of acoustic neuroma removal.
Scientific knowledge has certainly changed in our field. What do you think were some of the big breakthroughs? Because you've seen it all starting from the beginning. What do you think is one of our biggest breakthroughs?
One of our biggest improvements,
Mm-hmm.
the bottom line. And the bottom line is outcomes are better because of neuromonitoring. And it's hard to put a price on an improved outcome. And that's why we have to argue with insurance companies many times in order to get them to reimburse. We had an issue once later on in my monitoring career when there was an insurance company that said, well, we're simply not going to pay for it. If you want to do it, that's fine, but we're simply not going to pay for it. And that put me in an awkward position. I had to go to the surgeons and tell the surgeons, look, I can't do this for free. This costs a considerable amount of money. So I'm going to have to stop monitoring if insurance is not going to reimburse for this. And so then the surgeons said, well, I can't do the surgery without this. So he would go to the administrator of the hospital and he would tell the administrator of the hospital, we're not going to be able to do this kind of surgery. And the hospital would come back and say, oh, well, but that's a very common procedure. And we encounter this pathology often. And so we have to have you do the procedure. And so we said, well, how can we arrange this? The hospital said, well, we will pay for the neuromonitoring by contract. We will contract with people who do neuromonitoring and get them to perform the neuromonitoring, and we will pay for that. And the hospital at the end of the year has a financial facility that they can turn to, and things that they are not reimbursed for, they can charge off to various governmental agencies. And so we're back in the situation where we have the ability to finance neuromonitoring. And I think most people would choose to use it because of the statistically improved outcomes of surgeries that are monitored compared to those that are not.
That's correct. That's why we do what we do, better patient outcomes, right?
That's the bottom line.
Uh, What would you say you're most proud of in your professional life?
The thing that I'm most proud of, I'm proud of the teaching that the societies associated with neuromonitoring, like ASNM, the teaching that those societies do, the credentialing that the American Board of Neurophysiologic Monitoring does, that basically indicates that the person that's doing this neuromonitoring is adequately trained. That's what I'm most proud of, that we have created a plane of expertise, and this plane of expertise can now be certified.
Right. And you were a pioneer in the development of some of these programs, like what we know as ASNM today started out as the
American Society of Evoked Potential Monitoring, ASEPM. That's how it started out. That's the society that first started off. And
right.
as the society evolved, they changed its name to ASNM. And yes, I was a founding member of that society. I was also a founding member of the American Board of Neurophysiologic Monitoring. And I'm proud that I was able to do that, and that we were able to examine people and certify that indeed they had an adequate knowledge base to be doing operative monitoring. Those were very good things to have done.
Absolutely. What do you think the best piece of advice that you've ever received?
Keep your eyes open and your ear to the ground. Not the electrical ground, but uh, I had an unusual opportunity in my career at LSU. When I was in the Department of Neurology at LSU, there was research going on at the Delta Regional Primate Center in Covington, Louisiana. And once a week, I would go over there with either Dr. Hector LeBlanc, Sonny LeBlanc, or Roger Smith. And we had research going on primates over there. And I had the opportunity to actually do some of the surgery on the spinal cord of primates myself. This gave me an opportunity to actually watch what was happening to the blood vessels as I worked on the spinal cord. And I gained a very healthy respect for the phenomenon of vasospasm. When you mechanically stimulate blood vessels, you can cause the smooth muscle of those blood vessels to constrict, and that shuts down the blood vessels. And I was very much sure that this same thing was happening when spine surgery was being done on human subjects. As a consequence of that, I learned my first principle of, if the evoked potential monitoring tells me something bad is happening, I will turn to the anesthetist and ask them to raise the blood pressure. That elevation of the blood pressure helps to prevent or reduce the amount of vasospasm that occurs as a consequence of manipulation of the blood vessels of the spinal cord. So that got to be a very common thesis, and I think most people today will do the exact same thing. If they're in a surgical procedure And during that surgical procedure on the spine, the evoked potential monitoring is changed. The first instinct that they have is to raise the blood pressure and see if they can get the function to return to what baseline was.
Yeah. If you were given the chance to interview anyone, who would you choose in the field to interview?
One of the very authoritative people in monitoring acoustic neuroma resection was Augie Moeller. And unfortunately, Augie Moeller has passed away now, and he's not available for an interview. But he was a very authoritative figure, and his knowledge of neuroanatomy and neurophysiology associated with the auditory system was very comprehensive. So he would be a good person to learn from.
Yes, and thank goodness we have his books with all his
We have
documented
his book now.
research.
Yes, we do have his book at least. And his book is still very authoritative and still commonly used as a referral point.
So it's hard for me to believe, as you taught me IOM, I was one of Happel's girls. I can't imagine you doing anything else in your life. But if you wouldn't have gone into evoke potential intraoperative monitoring, what profession would you have chosen?
Uh, Maybe I could have become an itinerant ukulele stringer or something like that. Uh, I don't know what I would have done. I had all of the background in electronics, in physiology. Uh, my interest was in spinal cord function. And when I was presented with the opportunity to join the faculty at LSU and go into this area with no reservations, I jumped at the chance.
And you've done a wonderful job. You've taught so many. What was your PhD in?
My PhD was in neurophysiology. After I came to LSU, I was only at LSU doing evoked potential recordings for a period of about 3 months when the head of the neurosurgery department, Dr. David Klein, noticed what I was doing and realized that I could help him out a lot. And so he went to the head of the neurology department and told Dr. Patterson, I want him in my department too. So I'm going to make him 30% neurosurgery and 60% neurology. And so I got to work with Dr. David Klein, who was a world authority in peripheral nerve surgery. I started doing a huge amount of monitoring peripheral nerve function during neurosurgery for peripheral nerve injury. Dr. Klein passed away, I guess, about 8 months ago. And before he passed away, we tried to put a comprehensive review of what we had done over the course of 40 years monitoring peripheral nerve surgeries. And the numbers that we came up with just blew me away. Over the course of 40 years, we recorded data from 27,000 peripheral nerve injuries. It made me realize why I got so tired. We did it a lot, and some of these surgeries would last for long periods of time. Dr. Klein was particularly motivated in and interested in surgery to the brachial plexus. Those surgery procedures for brachial plexus injury would often last 18 to 20 hours. And we would be in the operating room for 18 to 20 hours recording peripheral nerve activity as he evaluated different components of the brachial plexus. We had ample pathologic material. The city of New Orleans had a very active chapter of the Knife and Gun Club. And so, as a consequence of that, peripheral nerve injuries, especially to the brachial plexus, were quite common.
Wow.
And we did so many of those.
I also want to ask you, how did that evolve into spinal monitoring?
I came to LSU in 1970, and so I got involved with doing evoked potential recordings in the Collaborative Child Development Program and with teaching EEG techs. And I did that for quite a few years until finally Dr. Andrew King asked me if I could do evoked potential recordings during spine surgery. And I said, yeah, I think we can do that. And we did one case at Charity Hospital. And the outcome from this case was particularly good. This was a young man who had a severe kyphosis. And during his correction of this kyphosis, we lost all spinal cord function. When I told him that, he was really upset. And so the only thing he could think of to do was to release the correction that he had placed on this young man's spine. And when he released the correction, instantly spinal cord function returned. And so he put some correction back, but not as much as he had originally. And the spinal cord function was maintained. And the bottom line of this case was when the patient woke up, he was capable of walking, using his legs. His spinal cord worked just fine. So Dr. King then asked me, well, can we do this at Children's Hospital? And so I said, well, I'm not credentialed at Children's Hospital, but I have my credentials at Charity Hospital, and we'll see what we can do. At that time, the medical director of Children's Hospital was an anesthesiologist, Dr. John Heaton. Dr. Heaton was a very imaginative guy and a very forward-looking guy. And he said, yeah, let's see what we can do here. And so the only way I could get on the staff of Children's Hospital was to be hired by Children's Hospital as a contract employee under the direct supervision of Dr. Heaton. And this is how it came to pass. So we started doing operative monitoring on the big spine cases, on some of the brainstem cases, some of the neurosurgical cases. And that's how neuromonitoring got started at Children's Hospital. Over the course of many years, Dr. King and I have worked together, and we have many instances where we have been able to identify an evolving problem that was highly correctable, which we corrected, with the outcome of a good result from the surgery. And so I have to thank Dr. King for his efforts in getting me to work at Children's Hospital.
So you were not only neurology, neurosurgery, now you were orthopedics too.
That's right. I actually got to do a lot of orthopedic cases. And some of the orthopedic cases even expanded beyond spine. During cases of hip replacement, it was necessary to disarticulate the hip joint. And the orthopedists who were doing that noticed that there was a lot of incidence of peripheral nerve injury. When the sciatic nerve was extracted and pulled on to dislocate the hip joint, often it created an injury to the sciatic nerve. And yes, we can monitor for that. So that became one of the procedures that we would frequently monitor. And I would add not only orthopedics to what we monitored, but the urologists got real interested in what we were doing and wanted to know, could we monitor from pelvic floor nerves? Because they had a lot of incidents of pelvic nerve injury in the pelvic floor. And so we started doing that. And as we did that, the urologists actually got their own system going, and they had their own people and their own equipment to monitor urologic function during pelvic floor surgeries. So it grew very, very rapidly. And I am grateful to have participated in that.
Through the years when I started working in intraoperative monitoring, in the beginning, we were only doing somatosensory evoked potentials. Do you remember that?
Yes, I do.
And we evolved
We
together
evolved.
with your
The,
oversight.
the spine surgeon said, it's nice to be able to prevent problems to the sensory system, but what we really want to do is we want to protect the voluntary motor pathways. And so in the 1980s, there were people who were trying to develop a method to evaluate the motor pathways. And they started off with trying to do transcranial stimulation of the motor cortex to evoke movement that we could then record an electrical event associated with and thus assess the motor pathways. This was crude to start off with, and the parameters of stimulation were a little bit scary. This motor evoked potential process began at St. Louis, in the hospitals at St. Louis, and they would stimulate transcranially using electrical pulses of about 2,000 volts. And I remember going to a meeting once where somebody stood up and asked, don't they call that capital punishment? Well, uh, well, be that as it may, we got better and better at it, and we got the techniques of stimulation, the motor cortex down a little bit better, where we could use much, much lower voltages. And that was much more appealing. And now there is a fairly common use of motor evoked potentials during spine surgery, as well as somatosensory evoked potentials. The more tracts that we can evaluate during surgery, the more accurate we can be in stating that things are working okay. The surgeons got to be pretty demanding, and as surgical procedures were underway, they would frequently ask, how is everything? And expecting an instantaneous response, which we couldn't give, it took about 3 minutes to perform the testing that would evaluate these pathways. And we would have to say, well, give us a couple of minutes. We'll let you know in a couple of minutes if everything is okay, which we had to then do the testing. And then we could give them a response to say yes or no, everything was okay or not okay.
Yeah. And to facilitate some of those requests, I recall you being able to create instrumentation maybe to help us along the way.
Yeah, we had several things that we could use. I'm not really a surgical equipment manufacturer, but there were pieces of surgical equipment that we could use that would facilitate these recordings. But that was something that really has not become very commonplace. Most places still use transcortical stimulation and the recording from muscle groups in the legs to see if there is conduction in the motor pathways.
Mm-hmm. And before that time, remember when we started descending evoke potentials before we had the motors, we were doing descending evoke potential stimulation. And I remember we had to apply the needles, but they had a Teflon coating. So you would actually shave those needles for us to remove
Yep.
some of the Teflon coating so we could stimulate.
We could stimulate cervical spinal cord and record motor events in the legs. That was a process that we went through for a while. But then eventually the transcortical stimulation took over from there. And it was a little bit easier to place electrodes on the scalp
Right. No
because
more shaving down electrodes
no more shaving down electrodes, no more
and
trying
having
to.
them realize re-sterilized. And I remember in one of the cases they'd ask for the Happel adapter. Tell us about that.
Oh,
I remember all kinds of things.
yeah, you remember better than I do. I'm trying to remember what that was. I remember we had an adapter, but I don't really quite recall what that was.
It was part of the stimulation process. Might have to refer to Andy King on that one.
Yeah, I'll have to see if you can refresh my memory here. I hope I'm not having the same problem that my wife has. My wife has Alzheimer's, and so this really changed my course of action because my wife started to develop Alzheimer's about 2015 or so, and I was her primary caretaker. And I was her primary caretaker until 2023 when I had an event myself. I had an intestinal bleed, and in the middle of the night one night, I almost bled to death. And that changed the course of pretty much everything for me. Following that bleed, I got to be very weak. And in early 2024, I fell and broke my ankle. And the orthopedist that I went to x-rayed my leg, x-rayed my ankle, and he told me, he says, I've seen this happen time and time again. I can put plates and screws on the broken bones, but I can tell you that if I do that, you're going to have a lot worse arthritis than if I just leave it alone and let it heal. And so I took his advice and I let it alone, and it has healed, but it still gives me problems. I still have to walk with a cane. And so have not quite recovered from a broken ankle.
Goodness. Well, we're sorry to hear about Bonnie. And yeah, sometimes we have to make hard choices in life. It's not easy.
Yeah, it really isn't. It really is not.
So I'd like to hear one more story from you. I want to hear the story since you've retired, the call that you recently received. You said people still call you.
Yes. Okay.
Let's talk about that quick call. Well, it wasn't a quick call. It was a quick call to you, but it was
Okay. Here's the story. There was a young man who was born with a birth injury to his right brachial plexus. This injury was so bad that he had a flail arm as a result. He had no voluntary movement in his arm. And so it was not a good idea to try to repair this injury right away. The surgeon chose to wait and see what was going to happen, and he waited till the child was 6 years old. When the child was 6 years old, the neurosurgeon chose to do surgery on his right brachial plexus. And he calls me on the telephone. He says, I'm in the operating room now. He says, I've got his brachial plexus exposed. He says, I'm stimulating elements in his right brachial plexus, and I'm watching his right hand, and the fingers of his right hand move. How can that possibly be? This child has no voluntary movement whatsoever. How can that be? What does it mean? And so I explained to him, over the course of 6 years, this child has had a small number of axons grow from his right brachial plexus all the way out to the intrinsic muscles of his hand. These fibers are very few in number, and they create very small motor units. What you are doing when you stimulate is you are artificially synchronizing what few motor units remain going from his right brachial plexus down to his hand. And those few motor units, when they are synchronized together, can produce visible contraction of his hand. However, those motor units are so small that they cannot be incorporated into voluntary movements to create voluntary movements of his right hand. So you have to treat this as if this was a complete injury to his right brachial plexus, and those elements in his right brachial plexus still have to be repaired. That was a complicated picture, and it was a call that I had to make that indeed his injury was still complete. It was not a case of his injuries had healed. It's just that the case of those nerve fibers grew back, just a few of them, over the length of his arm, and they could now mediate movement if they were synchronized by electrical stimulation.
Very impressive. You never cease to amaze me, Dr. Happel.
Well, this is what I was meant to do. This was my calling.
I truly believe that.
I had the electronics background, I had the biology background, and the circumstances just came up where I could pull all of that together, and it created a wonderful career for me.
Right. Well, I would like to say thank you very much for taking the time to do the interview. From Asset Historical Society, we truly appreciate the opportunity to interview you today and hear all of your history and how evoked potential and intraoperative monitoring have evolved today.
Well, it means a lot to me that you were the person on the other side of the screen here asking the questions, because I have to tell you that I appreciate all that you have done. You were a gifted person, and I recognize that you were a gifted technologist, and I have had ample opportunity to recommend you as someone who was particularly capable.
Thank
So
you.
it's been a pleasure working with you.
Thank you very much. That is very sweet. I wouldn't be where I am without your help and
Well, it probably
guidance.
works both
Certainly
ways
were my
because
mentor, and I was excited when I was asked to do this interview for you. So
cool. Well, I'm glad to do it. Glad to do it for the society. Glad to do it for you in particular.
Dr. Happel, you've done a significant amount of research in our field, and I'm sure you have been awarded.
I have been, and it was indeed a great and special honor that was conveyed on me at the ASNM meeting in Orlando, Florida. I was designated as the recipient of the Richard Brown Lifetime Achievement Award in operative monitoring. And I still have that plaque, which has a special place in my heart. Richard Brown is no longer with us, but he was a very good friend during his lifetime. And he really meant a lot to me.
Well, we appreciate you being one of the pioneers in our field and sharing your wealth of knowledge with all of us.
Thank you very much.